Thank you so much. Thank you so much for talking us this evening on addressing bias in care.
Thank you very much, Dr. Fayad. I have to say that I am very thankful that in a way we had a cancellation on our regular schedule EDI summer session for the department. And I'm very glad that we were able to accommodate this session based on already scheduled GI grand rounds. So thank you very much for sharing your GI rounds with the rest of the department and those that joined us today. I will start sharing the screen, and please let me know if you see the actual slide deck, because sometimes that doesn't happen.
It's perfect.
Okay, great. Thank you very much. So as Dr. Fayad mentioned, I want to talk to you today about unequal treatment and addressing bias in care. Many of you are very familiar with some of the topics that I will discuss today. For that reason, I have also left some considerable amount of time at the end to really have a conversation about how bias truly manifests in academic medicine and our healthcare systems. And, you know, given that we're largely focused on GI, I would very much also like to learn from the division and see where you actually are seeing bias manifest. With that, I want to do a land acknowledgement, as I usually do, in reference to where IUP-UI in the Indianapolis campus is located, so that we may honor not only the historic homelands of the Miami people, but also the displacement of a vibrant Black community around Indianapolis. And in doing so, we're also honoring them in our journey through diversity, equity, and inclusion, and obviously social justice. I also have to state, as I often do, that I have my own biases like everybody else. Having these biases is not necessarily a bad thing. We all have them, and it also serves many times as a type of defense mechanism. It's how we have made it this far. But if I say anything during this talk that really makes you think, offends you, or in any case, let's have a discussion about it. You may also email me to talk about the event that happened during the talk, or we can also address it during the Q&A. I'm always open to do so. In terms of the learning objectives, again, we're going to talk about implicit bias. We're going to talk about how it influences care, and then discuss some strategies that we can use to actually minimize or at least eliminate implicit bias. I will start specifically talking about this unequal treatment. So as you saw in the title, unequal treatment actually referred to this panel of experts that came together to talk about and document the evidence and explore how persons of colors experience the healthcare environment. This particular report did examine how disparities in treatment arise in healthcare systems and look at aspects of the clinical encounter that could contribute to the disparities. Patients and providers, attitudes, expectations, and behaviors were analyzed as part of this report. Here, you can see that they stated that racial and ethnic disparities in healthcare are known to reflect access to care and other issues that arise from differing socioeconomic conditions. But there is, however, increasing evidence that even after the differences are accounted for, race and ethnicity remain significant predictors of the quality of healthcare received. You might be very familiar with this report, and if not, I suggest that you give it a read because it is still very much relevant today. Other important takeaways of the report include this one, for example, and I'll give you several quotes as we move along, that racial and ethnic disparities in healthcare exist, They are consistent and extensive across a range of medical conditions and healthcare services. They are associated with worse health outcomes and occur independently of insurance status, income, and education, among other factors that influence access. And they clearly state that these disparities are unacceptable. What were some of these disparities that were found? For example, and I use this when I'm often talking about racism, discrimination, microaggressions in academic medicine and the healthcare system, that people of color receive lower quality health, even when, again, the insurance status, et cetera, are comparable. That people of color are more likely to be treated with disrespect by the healthcare system, and more likely to believe that they would receive better care if they were of a different race, mainly if they were part of the white majority. And obviously, again, going back to where they found these disparities, they're very broad in cardiovascular disease, cancer, stroke, kidney dialysis, HIV/AIDS, asthma, diabetes, mental health, maternal and child health, and the list can go on and on. Here's another quote from the report. It states, some racial and ethnic minorities express greater levels of mistrust of healthcare providers and the medical establishment than white Americans, citing obviously mistrust that have built up between minorities and the scientific and medical community. Other aspects that they list are that for almost all ethnic groups, respondents who reported experiences of discrimination were more likely to report a delay in seeking needed healthcare than those who did not report experiences of discrimination. And in this particular statistic, it's quite obviously shocking, but it's almost uniform, about 95% among Black African Americans who reported experiencing discrimination in the healthcare system. How did the experts define discrimination? They used it as an umbrella term that referred to the differences in care that result from biases, prejudice, stereotype, and other clinical communications. More specifically, when they actually talk about sociocultural differences, they specifically say that between patient and provider, these sociocultural differences aren't necessarily appreciated or explored, understood, or communicated. And it may result in patient dissatisfaction, poor health outcomes, and in racial and ethnic disparities in care. Well, the report, we commend, obviously, the report back then in 2002, 2003. The recommendations were vast in terms of improvements in medical care financing models, in the allocation of care, on even the availability of language translation services, talking about community-based care and its importance. They also highlighted the importance of cross-cultural education or cultural competency as a way to actually improve provider-patient communication, and offer a detailed look at how to integrate that cross-cultural learning within the health professions. And I have summarized it here as cross-cultural education or medical education. And then finally, it does provide information on perhaps the data that should be collected, as well as research initiatives. So where are we post 2003? So again, this report is 15 years old. I told you that if you can still read it, it will still be applicable. And I'll show you some of the reasons why. Again, this is another statistic that I often use. This statistic talks about bias, racism, and discrimination. It specifically talks about the percentage of individuals that felt discriminated against when going to the doctor or health clinic because of their race or ethnicity and gender. Here you can see the percentage for white is 5%, but for Black African Americans, it's 32%. For Latinos, Hispanic, or Spanish origin, it's 20%. For Native Americans, 23%. For Asian Americans, 13%. On the right hand, you can see again the difference between men and women and members of the LGBTQ community. And you can see that 18% of women felt personally discriminated against because of their gender. And of course, I do believe that probably the number is higher than what is represented here at 16% for the LGBTQ community. So what have we done in academic medicine lately to actually try to combat what is deemed as implicit or unconscious bias in medicine? So I know that many of you have heard about implicit bias and unconscious bias, and I don't intend to this be a whole lesson on what this is. But I do have to give you a refresher that in terms of implicit social cognition theory, and more specifically, implicit attitudes, we're really talking about over 20 years of research on this. And academic medicine has just basically been embracing it recently with all the initiatives that you have seen in regards to implicit bias. So here's one of my first bias statements that I will make. I do not believe that in training implicit bias and how to combat and all that is the sole answer. I don't think that we should treat it as the answer to eradicating racism, discrimination, but I do believe that it's one of many important tools in professional development in that awareness of your own implicit bias that will cause you to actually take action against discrimination. Implicit attitudes by Greenwald and Benaji actually meant introspectively unidentified traces of past experience that mediate favorable or unfavorable feeling, thought, or action towards social objectives. So specifically to implicit bias, this means the mental associations without any awareness, intention, or control. So when we think about implicit bias, we can refer to it as the attitudes or the stereotypes that affect our understanding, actions, and decisions in an unconscious manner. This is not something that we are very much aware of, and many times it's actually counter to what we believe. They are involuntary. They happen, again, without any awareness. They are robust and they are pervasive. Everyone is susceptible to them, even when we believe ourselves to be impartial and objective, we still can see it documented. Because of this implicit associations and how they arise, they don't necessarily align, again, with what we believe. You may see me as an equity scholar, somebody that is truly dedicated to diversity, equity, and inclusion, but I can tell you wholeheartedly that I still have my own biases. And even though I still talk a lot about microaggressions and how to combat those, I'm actually also complicit in the system and a culprit when it comes to committing them. The bias in healthcare is broad. Presumably, we would address everything that was in the unequal treatment report, and we would also address everything that shows up in the research literature, but that is not necessarily what is happening. We see bias in healthcare in its presence in healthcare professionals, so you as physicians and healthcare providers, we all have them, and they impact the patient care that we give. We have obviously plenty of studies that show how racial biases can lead to differential treatment of patients by race and how they can impact clinical decision making. We also see them in the way that communication happens between a patient and a physician. Studies actually have shown that it's deeply rooted in unconscious bias and how we communicate with our patients, depending where we deem our patients are coming from or what group membership they may be part of. I always add medical education to bias in healthcare because we are educating the next generation of physicians. And even through that process of medical education, through the process of admissions, through the process of nomination, through AOA and other societies, the process of clerkship grading or even evaluations, in the way that we actually carry our learning environments and write letters of recommendations, all that is subject to bias. Even though we are trying to counter in academic medicine in many ways, the way that we approach these issues through cultural competence, we're still not there yet. I also think that our medical students are at a way that it's more advanced than our faculty are in being open about talking about these health disparities and how really bias manifests in the healthcare system. Now, with that said, I would like you to participate, and I'll try to find my chat here. So if you don't mind typing for me, that will be really appreciated so I can feel some of the energy at 5 o'clock today. So I want to ask you, what happens when you think about pain management? So it doesn't have to be a full sentence. It can be, a few words. But if I were to ask you, what comes to mind right away when you think about pain management for your patients? And I'll wait a little bit. And Dr. Fayad says drug addictions, difficult. You can help me out with a few more. Frustrating. Redheads need more. I have never heard that one. Uncontrolled. Minimize narcotics as much as possible. Narrow therapeutic window. Quality of life. As a patient can't be that bad. Constraints to treatment. Good. Does anybody feel like expanding on any of these? And you can certainly unmute yourself. We are amongst family with how many? 89 members of your family. Count them. Nobody wants to expand? Okay, I'll give you another one. So what do you think in terms of women presenting with cardiac heart disease? What thoughts come to mind? Anxiety, obesity, yeah. Symptoms may be minimized by the woman herself, yeah. Atypical presentation, not chest pain, yeah. They neglected their care for a long time, yeah. Again, I want to give you the opportunity if anybody wants to speak up and share a thought, that will be fine too. Okay. So what about risky behaviors? What comes to mind when you think about risky behavior? Motorcycle as a risky behavior, yeah. Promiscuity, heavy alcohol use, yeah. Smoking, drug use. Okay. What kind of picture comes to mind Oh, refusing COVID vaccination, absolutely. What kind of thought comes to mind when you think about the individual? What kind of characteristics does that individual have? How do you picture them in your head in regards to risky behavior? I see impulsive, Kristen, yes. Deceptive. Any other ones? Politically polarized, yeah. Mental health issues, depressed, careless, yeah. Young male, lower level of education, yeah. Poorly educated. Good. I said good in terms of thank you for your contributions, not the discussion. This is good. But I do have to share with you that the literature has shown that white male physicians are less likely to prescribe pain medication to Black patients than to white patients. That often doctors assume that they're Black or low income patients, and this includes Hispanic and Latinos, might be less intelligent and more likely to engage in risky behaviors and less likely to adhere to medical advice. There's also the literature that shows that pregnant women face discrimination from healthcare providers on the basis of their ethnicity and socioeconomic background, that women presenting with cardiac heart disease symptoms are significantly less likely than men to receive diagnosis, referral, and treatment. And often the misdiagnosis is actually stress and anxiety. So health disparities are often considered to be racial or ethnic issue. And of course, in my presentation, I'm focusing on these two, but people are truly subject to unconscious bias based on many factors, including sex, sexual identity, socioeconomic status, education level, age, disability, geographic location, etc. And this actually is a little bit of expansion on some of those examples, that non-white patients receive fewer cardiovascular interventions, that Black women are more likely to die after being diagnosed with breast cancer, that patients of color are more likely to be blamed for being passive with their health care. So again, in an effort to encourage conversation, I would like to see if anybody, if any of these statistics and literature results have been of surprise to you. I want to know that. It doesn't sound like it. Okay. So again, the title of this presentation is Unequal Treatment in Addressing Bias in Care. So how do we actually address the bias piece in care? I have spent a lot of time looking at literature on this, and I can really summarize this in terms of debiasing. And this is an actual term, it comes from business literature, that states that debiasing is a continuum ranging from the reframing or repackaging of existing information to the provision of new strategies for thinking about information. In the way that I have summarized this, I'm just going to give you the two nuggets that I think are key in debiasing. One is the professional development piece, which is, to no surprise, something that I talk about, and this round actually offers an opportunity for doing that. And then obviously the culture change. So in the business literature, they talk about modifying the decision maker and modifying the environment. So I think about it in terms of modifying the decision maker as an opportunity, again, to provide professional development that draws upon this debiasing research on the benefits of education, as well as providing opportunities to think about the strategies and formal decision tools that people can be taught to use to be part of the solution. When I think about modifying the environment, that's when I think about culture change. Modifying the environment really means to alter the environment in a way that provides a better match, where people can think about debiasing in a way that is actually natural, that it's part of what we do every day, that we are encouraging this better thinking. I think the culture change also, along with the professional development, provides an opportunity for all of us to practice reflection, to make active choices that say that you will stand up when you see racism, discrimination, and bias happen. For an opportunity for us to make a very clear and explicit commitment that we believe in diversity, equity, and inclusion, and social justice. And that in doing so, we are committed to eliminating biases in the healthcare system. And then also how this may give us an opportunity to frame these messages a little bit differently. So how do we fix it? Which I know that every time that I give a talk, people actually want some solutions. Let's stop talking about the things that we already know, right? If you ask me, right, do I need to see another health disparity study? Probably not. I am ready to actually eliminate that disparity. But it takes all of you, it takes all of us, and it takes a few more. But certainly that should not discourage us. So in terms of strategies to address bias in care, again, I have summarized these into 3 categories. One is enhancing our conscious efforts and motivation. And we can do that by creating counter narratives of stereotypes. For example, I want you to take just 10 seconds and think about a stereotype. I'm going to time myself. So now that you have thought about that stereotype, what kind of counter narrative can you give it? For example, I'm going with women are bad drivers. Maybe that was a stereotype that came to mind. So what will be the counter narrative? No, some men are bad drivers too, and women are also good drivers, right? So I know that that is a very simplistic way of saying it, but you can create these counter narratives of stereotypes that will help in making those. Kristen says she's actually not a very good driver. I didn't mean to read that out loud, Kristen. The other aspect is this multicultural interaction. We often talk about the bubble that we live in, right? This bubble is pretty much your family and your friends, and very rarely we actually expose ourselves to different environments. So this is, again, a conscious effort to actually interact with others, of members of groups that we might not be familiar with, that we might be curious to learn from. The other aspect is changing our mindset to this asset-based thinking. I see this all the time, especially when it comes to deficit-based thinking and the way that diversity comes up. As in, if we couldn't find excellence in the diversity that we looked at. Excellence and diversity are not exclusive from each other. So if we actually think asset-based thinking, then we're really embracing the fact that being diverse will actually create more of an excellent team and will make the institution excellent, the department, the division, etc. Asset-based thinking really is not just thinking about, the barriers and oppressive structures that, for example, our patients are of color or faculty of color experience in academic medicine, but it's also thinking about all the great things that they bring to the table, and then working with those things. The second strategy can be summarized in terms of practice, practice, practice. And I know that as physicians and practitioners, we love a good checklist. So I will talk a little bit about the tool of pause. There's the other tool that you may have participated through our workshops on how to respond or responding to racism, discrimination, and microaggressions, in which we practice the open the front door tool. You can also see it in the way that perhaps you have already practiced simulations. We have a very good sim lab at IU, in the way that you may practice scenarios or may actually role play. And then there is a wealth of cross-cultural communication tools, and they are all over the literature. Again, we provide some workshops in relation to these tools in combating racism, discrimination, and microaggression. The third area is enhancing perspective taking and empathy. And in here, I put positive emotion, because positive emotion, it's been told to facilitate empathy, and it may increase the capacity to see others as members of a common in-group. So seeing them as part of your group. We can also practice more cultural humility. And again, those of you that are here are probably not surprised that I often talk about cultural humility in many ways, in the ways that we can create a framework for advancing conversations about race and equity, but also in the way that we can practice them at the individual level, at the personal level, and we can see our own growth through that. And also embracing the lived experiences, not just your own lived experiences that can only happen through self-reflection, which again aligns with cultural humility, but also learning about others and their own lived experiences. Dr. Anne-Marie Montero adds that positive emotion increases accuracy in decision-making too. Thank you very much. So let's be a little bit more specific in terms of that recipe for how we can actually approach bias and address it in care. There's this tool called PAUSE, and PAUSE stands for paying attention to what's actually happening beneath the judgments and assessments. So as part of the cultural humility framework, we have talked about reflecting perhaps after every clinical encounter. And that may be too much, especially for those of you that have just 15 minutes between encounters. But maybe at the end of the day, again, thinking about how those interactions went. Did you feel that you exhibited humility? Do you feel that you were curious, that you wanted to learn more about that individual? Did you find yourself actually stereotyping a patient? And because of that, could it have affected your clinical decision-making, or even, again, the treatment that you suggested? A stands for acknowledge your own reactions and interpretations on those judgments. So once you have actually reflected on these, what kind of feelings they cause? Do you, in that reflection, feel that, oh, maybe I shouldn't have said that, or there was something that you feel uncomfortable with? That's when you actually own it. And decide how you're going to act now that you know what you did and how you felt about it. Understand the other reactions, interpretation, and judgments that may be possible. Again, in that scenario, thinking perhaps, what did the patient think once I said X, Y, and Z? If it didn't make me feel comfortable, what do I think? What could the patient have felt at that moment? And then searching for the most productive ways to deal with that situation. Again, if it means that you need to actually follow up with that patient, apologize, or address the issue in a different way, that is okay to do. The most important thing is that you actually execute your action plan. It often comes about when I talk to faculty about either a racist or discriminatory or a microaggression that maybe that they have performed. It actually sticks with you in ways that are not necessarily going away. I actually had a discussion, this was a while back, with a faculty member who said, I didn't do anything about whatever the item was. We don't need to disclose the situation. But I did ask her, okay, so when did it happen? Would you be able to go back? And it had been almost a year. So again, this is proof that they stick with you. And if in all this awareness, if you don't address them, we are not moving the needle. And many times that's what we need to actually address and eliminate the bias in healthcare. I want to also bring BRIM to the mix. And I know that all of our faculty, and I don't know if there's others outside of the Department of Medicine here, but for 2 years, we made the push for participating in the bias reduction in internal medicine study. I know GI went in this recent round, but I want to add these as a reminder of strategies that can be used to actually eliminate bias. One is to recognize, label, and challenge those stereotypes. It really involves being simply being more intentional in recognizing when you see stereotypes portrayed around you, that you actually label them as such, and that you're challenging those stereotypes in ways that make you perhaps say, well, some individuals may be this way, but some may not. That believing that with the second one, recite growth mindset and internal motivation messages, is believing that with hard work and perseverance, new behaviors can be learned. So believing that engaging in any behavior is a personal choice. So again, being an active or an upstander, intervening when you see these types of situations come up is really important. And it's part of that growth mindset in believing that you can change this behavior. Individuate and perceive variability. It's really about seeing each person as a unique individual rather than jumping into generalizations from a group stereotype. That is pretty clear in the way that we actually see patients. Not so long ago, maybe a couple of years ago, I received a call about asking for expertise in a specific culture. But the way that it was framed, it was clearly not that a specific cultural competence or knowledge or expert was really needed. At the end of the day, it ended up being about faith and not about the continent the individual came from, the country or the tribe or anything like that. It was truly about the individual patient's spirituality. And once you cross that road, then you realize that we are not much different. The next area is practice perspective taking. And perspective taking sounds pretty fancy for just another way to say, put yourself in other people's shoes. Imagining in detail what it's like to experience the world as they do is actually key, a key exercise. For those of us as faculty, especially as you interact with patients, it might be, or even putting your shoes in putting the shoes of your colleagues. Think about what it will be like to have your own skills, abilities, leadership potential filtered through an expectation of negativity, of a negative stereotype or expectancy bias, right? That you are not necessarily good enough. And then the last strategy that we discussed during the BRIM process is to act, to be an upstander. Individuals that actually stand up when they see these racism, discriminatory behaviors happen, including the microaggressions. So with that said, I wouldn't be necessarily an educator if I didn't give you homework. So as part of this exercise, I would like you to actually think about just one thing that you can do to eliminate bias or to practice in terms of exercise and in addressing the bias in care. And that can be in many forms. It can be your commitment to do any of these things where you say, you know, next time I think about a stereotype, I'm going to actually switch it around and tell myself a different narrative. Or committing to, once you have an individual patient from a particular group that you see as a member of a particular group, to actually make sure that you are treating them as an individual and not treating the culture itself. So these are some examples of, you know, what you can commit in terms of your homework. I'm not going to necessarily ask you what you choose right now, but as you know, I am big on accountability. So if you want to email me and let me know, Sylk, here is my homework, here's what I'm going to work on, just let me know, because every now and then I will send you the email that says, have you been working on this? A final way to actually think about addressing bias in care, especially as a community of in the division, is to actually think about pointing it out, being a role model, and speaking up. When I say point it out, it just means that you're the person who will actually openly talk about it, that you will do it in a collegial kind of way, in a professional way. You would address it with your colleague, but that it's important to actually point out when those instances happen. Be an example, be a role model, respect people regardless of what society says about them. That is obviously something that we should role model all the time. And then speaking up, you know, how do we challenge those around us to reflect and engage in these open conversations? So point it out, be an example, and speak up. With that said, Nabil, let's see, it's 5:46 here. I would like to end it here. And again, have an opportunity to have more of a questions and answers and a discussion as a group about how you may address bias in care. Perhaps you want to share what your latest experience has been, what you have witnessed, and maybe use the group here as a peer mentor, as a peer group that can actually provide some answers, or actually enact some changes either within the GI division, or again, I know that we opened it up to everybody, but this is an opportunity to actually have a good discussion about this. Let me stop share here.
Thank you so much, Sylk. That was a fantastic review. I'm going to get started with one question for you. So you discussed mostly bias in care. You touched a little bit about bias in education. We have fellowship interviews coming up. What's the best advice you can give to our faculty as they're interviewing candidates to minimize or mitigate bias?
Nice setup. So we have actually discussed a little bit about fellowship interviews, and they don't differ very much from what we would hope also for residency, right, interviews. You know, some of the things that show in the application process, especially if you have the first thing that you open the application, might be a big picture there of the profile picture of the individual. That automatically often triggers our own biases based on what we think or what we see that the individual looks like. The next bias piece comes as soon as we see the name. We may actually feel that, oh, their name is not Joe Smith, although we have Joe Smith. So I hope Joe doesn't take offense. But, you know, when we see a different type of name, it also triggers our conscious. And different type of name means something that we perhaps are not familiar within our particular group. Depending also the types of interview questions that you're asking fellows, bias may come through, and you may find yourself that you are more inclined to give a positive feedback to somebody that shares even your hobby interests, saying, oh yes, we need another golfer in the division. I don't know if that's the case, but just thinking about that, this is not just about race and ethnicity, that our biases actually show up in different ways. As I mentioned, again, sexual gender identity or the geographic location. We may also be biased when we think about the institutions that individuals actually came from, right? We might have our ideas of what Ivy League, candidates might be, as opposed to state schools or something along those lines. So as you're reviewing applications in preparation to interviewing individuals, just be aware that some of those biases actually may come up, and that the way that you counter them is to actually be aware of them in having different types of conversations that may actually get you to know the individual in a different way that is not necessarily completely tied to that alignment or that fit, if you will, with your own beliefs. So those are some examples, but I do hope, Nabil, that we will have some sort of guidance document soon at the end of the year or the beginning of the year in actually, improving those conversations, those interviews with residents and fellows.
Thank you very much. Let me say, I don't see any questions in the chat, but feel free to.
Somebody has to write a question in the chat.
You can either unmute yourself or write question in the chat room. This is a fantastic discussion. I encourage everyone to participate. I
would love somebody to actually share how they may have, experienced or may have seen an instance of bias within the healthcare system or clinic or something like that. I can always use a different institution. So you can also say that it was in a past life or happened to a friend and not to you, or whatever the case is. But I think that we need those examples to actually make it more personal and knowing that it actually happens here. Wait, is GA rounds always this quiet? I know many of our faculty and you're all not this quiet.
Gastroenterologists are very shy.
Well, so this is Lauren, nephew.
Hi, Lauren, how are you?
I'll share some anecdotes. My mother was at the clinic, at an IU clinic maybe 3 months ago. She was really upset because when MA or person checked her blood pressure was elevated, and she told her, well, you really need to start taking your blood pressure medicine, and really chastised her about taking her blood pressure medicines. And my mom's a Black woman, in case you wondered. And she is the most conscientious person about her blood pressure medicine. I can't even tell you. And so she was pretty outdone that this woman would be that presumptuous to suggest that the reason her blood pressure was elevated was because she hadn't taken her medicine, which was really because her blood pressure was mostly elevated because she had been running in and she couldn't find a parking space. And when the doctor retook it, it was normal. And I think that those things seem minor to people, but when you experience these type of microaggressions on countless medical encounters, it just gets tired. And I could probably name at least another 6 or 7 that I've experienced and people in my family have experienced. And so it's exhausting. And it gives people don't want to come to the doctor. My mom had a doctor's appointment this morning and she's reluctant to go. She's like, well, can't you just look at my labs? I'm like, I could, but you really should go and let someone else look at your labs that's not me. Because it just sets up a bad taste in your mouth when people have these preconceived notions about how you manage your care, your compliance before you even walk into the room.
Before you even, thank you, Lauren. That's a perfect example. Yes, thank you for sharing. I actually had an instance, to be exact, November 2020, when I needed to actually have surgery. And at that point, I even wonder, for, again, somebody that has been in academic medicine for so long, I couldn't help but wonder if my complaints were, or concerns, excuse me, were ignored. I never said that I worked at IU Health. I never said that, you know, I was in the Department of Medicine. And then it really made me mad that I consider like, oh, I have to say these things in order to be treated with respect and actually, you know, taken seriously in terms of the way that I was expressing my own concerns. And it's maddening that you have to think about that. Anybody else? So let me ask a question. In the example that Lauren had shared, if you were there in the room as a witness, how would you have handled that with the MA? What could you have said? And anybody can unmute yourself.
Sylk, I think part of that would also be generational, because when I was younger with my mother, we were taught the doctors know what they're doing. You don't argue with someone who knows exactly what they're doing. So, you know, it's hard sometimes to remember that you have to speak up.
Mm-hmm. Yes. Thank you, Rebecca.
Sylk,
Amy?
you know, it's really hard in the moment, which is why we're all here today, and we're going to learn about being an upstander. I mean, you could just say, well, I just ran in, like remind that MA, because that's common, right? Most of us don't give ourselves a huge cushion of time when seeing the doctor. We're often rushing or nervous.
So if you were there, Amy, what could you have said? You know, and this is not because I don't believe this is important. We also need to educate our patients, right? Like to really be in that situation where they can say, oh, you know, I ran in, but you know, as colleagues, again, how could you handle that situation with the MA on a one-on-one?
If you could speak to her, I would probably try to get her as soon as she left the room, and just say, hey, you know, you shouldn't make that assumption, and remind her people are often rushing.
Yes.
And also, and I might also add, maybe this is my physician bias. I actually don't think that's the MA's place. I don't go to a doctor's office to be told by the MA medical advice. I want the physician to tell me the medical advice.
Thank you, Amy. So again, in Amy's response, she would immediately try to address it with the MA and point it out and correct it in a way that it didn't seem, you know, that it would elicit any conflict or anything like that, but just a gentle reminder.
So I agree with Amy that to address this with the MA separately afterwards. So, because I think this is also an issue of educating our MAs and all the other healthcare professionals, not just the doctors, about this issue. Because I mean, maybe I'm wrong, but that might be my bias, but I don't think that was by default an ill-intended comment. It's just ignorance more than anything else, and bias. So maybe that's where more efforts into educating the other members of the team are equally important as educating the doctors about bias and so on.
Absolutely, and I agree with you, Nabil, in the sense that, going back to that development piece, right, that it's part of the education process, and that's how, at the end of the day, we are trying to change culture. So I do appreciate that comment. Now, I know there's only 1 minute left, so I don't know if anybody has a question that or a comment they want to share right away.
Yeah, so just one thing, I think in this kind of the same line that I think we do assume a lot. There's a lot of implicit bias in our clinics, in our hospital systems, and we do need to tell each other and tell ourselves this all the time because, it has happened to me and I am the perpetrator also. So I think we realize that, but the important thing is to know the tools to stop yourself, and also to, when you see something like that happening, the kind of tools that we can use to educate people without ticking them off, if you will.
Yeah.
Because that can be, like sometimes, fellows might assume certain things, or, or somebody will come in and say, and roll their eyes on a certain complaint that the patient has, or just come in and say things like, oh my gosh, that patient is so difficult. So coming out of that mindset and reminding ourselves that we need to see the patient as a person rather than a patient, and it's very easy to let our emotions drive us, and so it's really hard. And I remind myself of that every day, and still see myself in the same scenario many times.
Yes. There's something that you said, Hala, trigger my thought on the labeling issue. So I have talked about the problem with labeling, and again, labeling that patient as difficult runs the risk of us thinking about patients from that particular group are all difficult in nature. And then the switch really is, especially when we're doing medical education and talking to our students, we're really teaching them that there's really no difficult patients, that they're difficult situations, difficult scenarios, right? The same way that we will say, it's not diabetic patient that we're talking about a person with diabetes. So in that way, we're really challenging, I think, some of those stereotypes, and really eliminating the risk of labeling our patients in certain ways.
Agreed.
Okay, Nabil.
Thank you very much. And hopefully with this input, we will handle the situation a little bit easier. It's very tough and very challenging, but your input, your insight has been very helpful, Sylk. Thank you on behalf of everyone, and good night, everybody.
Good night, everybody. We will send an announcement for the last EDI summer session, which is on pronouns, and you'll see that in your email coming soon.